A very good morning to all the dignitaries and participants. I, Dr. Aditi Kaur, Assistant Professor in Community Physiotherapy Department, on behalf of Dr. APJ Abdul Kalam College of Physiotherapy, Pravara Institute of Medical Sciences, Loni, extend warm greetings to you all on the occasion of World Cancer Day. In order to provide health care to the rural and tribal masses of this region, Pravara Medical Trust was established in 1972. Appreciating the academic research and healthcare activities undertaken by the Trust, Government of India recognized this institution as Pravara Institute of Medical Sciences, deemed to be university in 2003. Today, the institution is recognized as one of the finest institutions of India. Unique with its location and the outreach activities that is being provided to a population of around 6 lakh, a university is unique feat with 6 institutions operational under one banner. In a small village like Loni, a multi-specialty hospital provides the best healthcare to thousands of patients near and far. Pravara Rural Hospital has been conferred National Award under the category of Best Institution for providing services to senior citizens and awareness generation by His Excellency, late Honorable President of India, Shri Pranab Mukherjee, at New Delhi on October 1st, 2015. This place has a history of social transformation which began 100 years ago, and today the entire region has become a land of prosperity and role model for the entire country. This change is accredited to our founding fathers, late Shri Padma Shri Dr. Vittalrao Vikhe Patil and his son, late Shri Padma Bhushan Dr. Barasaheb Vikhe Patil, who has worked for rural and tribal people, awaken and enlighten them with the unique theme of think globally, act locally. The Physiotherapy Department was established in 1976 and extended the rehabilitation services. Dr. APJ Abdul Kalam College of Physiotherapy was started in 1997. This institution is named after the excellency of late President Dr. APJ Abdul Kalam sir. We are really fortunate that Dr. Abdul Kalam visited our Pravara campus on 15th October 2005 on his birthday and distributed around 1,000 true reaction orthoses to differently abled children. This institution has specialized centers exclusively dedicated to provide comprehensive care and rehabilitation of spinal cord injury patients, and the center is named after Mother of Soil, late Srimati Sindhutai Vikhe Patil Spinal Cord Injury Rehabilitation Center. This institution also has Linus Paume Student Exchange Program, under which the students full scholarship to visit prestigious Karolinska Institute, Sweden, and many other European universities under different programs. This institution is flourishing under the able leadership of Honorable Chancellor Dr. Rajendra Vikhe Patil sir. Before we proceed with our webinar, we must pay our tribute and acknowledge the inspiring vision and conviction of the great visionaries who pioneered movement of knowledge and created a future direction for thousands of fellow beings. Our founder father, late Padma Shri Dr. Vittalrao Vikhe Patil sir, late Padma Bhushan Dr. Barasaheb Vikhe Patil sir, and Mother of Soil, Srimati Sindhutai Vikhe Patil. Now, I request Dr. Pratneha Dumure to kindly take over the session. Thank you.
A very warm good morning to all. Before starting the webinar, I would like to show some highlights of our institute through a video.
मुची प्रार्थनान हेच मुचे मागणी हीच मुची प्रार्थनान हेच मुचे मागणी माणसाने माणसाशी माणसा समवागणे प्रांत भाषा वेश सारे संपुदे
धर्म जाती प्रांत भाषा वेश सारे संपुदे
एक निष्ठा एक आशा एक रंगी रंगुदे
वाटला अंधार दुःखाचा दरी सूर्य सत्याच्या उद्या उगवेला आहे खातरी
Thank you for watching the video. I hope you liked it. Now let's begin with our today's national webinar. I, Dr. Pradna Dumure, Assistant Professor from Department of Community Physiotherapy, Dr. APJ Abdul Kalam College of Physiotherapy, Pravara Institute of Medical Sciences, Deemed to be University, Loni. On behalf of Pravara family, I extend warm greeting to you all for today's national webinar, Scope of Physiotherapy in Oncology. I am honored to welcome our esteemed guest speaker, Dr. Gayatri Karnik ma'am. I am happy to share that ma'am is one of our alumni and she is currently rendering her services in cancer rehabilitation, Homi Baba Cancer Hospital and Research Center at Visakhapatnam. We are very glad to share with you all. Today we have organized a webinar on scope of physiotherapy in oncology. Oncology is a branch of medicine that specializes in the diagnosis and treatment of cancer. Cancer is the second leading cause of death globally. Approximately 70% of deaths from cancer occur in developed and developing countries. Physiotherapists are an essential member of multidisciplinary team, which is the key of successful rehabilitation and management of patients with cancer and palliative care. Physiotherapists conduct assessment of the needs of this patient in order to apply skill intervention which are vital for patients' independence and functional capacity. Physiotherapists are involved in rehabilitation and management of cancerous patients right from the diagnosis up to community-based rehabilitation, emphasizing the quality of life among cancerous individuals. Now I request Dr. Rakesh Sinha, Sir, Principal, Dr. APJ Abdul Kalam College of Physiotherapy, to deliver the welcome address for today's webinar. Over to you, sir.
Yeah, thank you, Dr. Panya. So good morning, all. So on behalf of Pravara Institute of Medical Sciences, deemed to be University, Loni, and Dr. APJ Abdul Kalam College of Physiotherapy, I, Dr. R.K. Sinha, the principal of Dr. APJ Abdul Kalam College of Physiotherapy, extend a heartily welcome to all of you for today's national webinar. And at the outset, I would like to pay my tribute to our forefathers, late Padma Shri Dr. Vittal Rao V.K. Patil, Padma Bhushan Dr. Balasa V.K. Patil, and Mother of Soil Sindhutai Eknath Rao V.K. Patil. I also thank the Honorable Chancellor, Dr. Rajendra V.K. Patil, and Honorable Vice Chancellor, Dr. V.N. Magare, sir, for guiding us in all our endeavors. I heartily welcome today's guest speaker, Dr. Gayatri Karnik, an alumni of this institute of, I think, 2004 UG batch. She went on to do her post-graduation or master's in physiotherapy from Mahatma Gandhi Institute of Medical Sciences, University of Health Sciences, in fact, in Mumbai in 2011. I feel happy to share that she has undertaken lymphedema management training from Lymphedema Training Academy in the UK, and also completed her fellowship in oncophysiotherapy at Tata Memorial Hospital. Currently, she is working as scientific assistant at Homi Baba Cancer Hospital and Research Center, Visakhapatnam, and also has been a part of clinical trials in cardiovascular and respiratory field. So I heartily welcome Dr. Gayatri Karnik, an alumni of this institute, who has agreed to deliver a talk on the topic of today, which is physiotherapy and scope of physiotherapy in oncology. It is always a pleasure and a very happy thing to see our alumni doing well in their life. And I always look forward to many such more associations in future. Now, physiotherapy in oncology is an upcoming branch in physiotherapy. Like recently I had been to this Karad Institute of Medical Sciences, where they had even started a PG program on this oncology, MPT in oncology. And I was there as an examiner for the first batch of students, the first year of first batch of students. So that's why I feel like this is a very, the latest upcoming branch where we have a lot of role. And I think Dr. Gayatri will be able to shed more light on our role, since she's working in this field. So she'll be able to tell us in a better way how well we can and how and what all we as physiotherapists can do in this oncology patients, in this role, what is our role in these patients. So without taking much of time, I would like to hand over the stage to Dr. Gayatri. And Dr. Gayatri, welcome once more, and please carry on with your lecture. Thank you.
Thank you. Thank you so much, sir. It's such a wonderful feeling to come back to the college, but virtually though. But yes, it's really a nice feeling. So when I was preparing for this PPT, preparing the things, I was just taken back to the time when we used to present during our college days on OHP sheets. From OHP sheets to this virtual thing, it's been a long journey. So like today I'll be talking about scope of physiotherapy in oncology. So as sir said that it's an upcoming field. Because what I remember from my UG days is we in our final year we were just given 2 sheets of paper on which role of physiotherapy in cancer was listed, and that was it. And whenever we used to study about other modalities or manual techniques, so one common contraindication which was there in almost everything was malignancy. So that led to a feeling that we as physiotherapists don't have any role to play in oncology per se. But when we moved out, when we started practicing, and when I went to Tata Hospital, that is when I realized that there is a department of physiotherapy which is running for more than 50 years probably now. So that made me think that okay, physiotherapy is not contraindicated always in oncology. Okay, so there is a lot that we can do in these patients. So today I'll just give you a brief idea about what will we do. Okay, so first, like what is cancer? So you must have studied that cancer is an uncontrolled growth of cells. So the cells basically do not undergo a normal cell cycle growth, this thing, but there is an uncontrolled and uncontrolled growth basically, and because of which the cells are not formed properly. And then, as you can see in this picture, the cell division is improper, and then that kind of forms a tumor basically, that presents in the form of a lump or a tumor. So if this thing is diagnosed early, then it can be cured as well. But if the patient presents in later stages, then the treatment becomes difficult. Okay, so now what happens when a patient is diagnosed with cancer? So cancer is not something which will affect the patient just physically. Physically, this thing is there. Obviously, the patient will have various symptoms depending upon where the tumor is affecting, which part of the body has been affected by the tumor. So that is one part, the signs and symptoms that the patient presents with. Apart from that, the treatment of it, be it surgery or be it chemotherapy or radiation, all these treatment modalities have their own effects and side effects on the patient. So that is the physical impact that the patient has to undergo. Along with that, the diagnosis of cancer itself is very disturbing for a patient, right? So not only that, plus this effects of the treatment that the patient is going through, that also leads to a psychological impact on the patient, right? So cancer affects the patient psychologically as well. Treatment of cancer is a very long process. Okay, it's not that it will be over in a month or 2 or a few weeks time. It goes on and on for months. Okay, so because of that, there is a lot of financial burden. A lot of chemotherapy drugs are expensive, so the patients might not be able to afford them. So that leads a financial constraint also on the patients. And because of all these things, obviously the members of the family are also affected, because somebody has to accompany the patient for treatment, somebody has to care for the patient at home as well. Okay, so that's why the family also gets affected, and because of all these factors, the quality of life of a person is affected. Now, why is it important for us to know about these things? So basically, when we are seeing a patient, it's not that we are just managing the physical symptoms or the problems of a patient, but we also have to take care of the other aspects as well. And if we, because we spend a lot of time with the patients, right? Because our treatment sessions are longer. Many a times we call the patients for a few days on a daily basis. So then we happen to spend a lot of time with the patients. So then we might come across certain factors where we might feel that okay, the patient needs probably a help of a counselor. So we need to refer the patient to a counselor. Or if the patient has, for example, lymphedema, managing a lymphedema, lymphedema kits are little expensive. the stockings which we give them are little expensive. So then the patient, if they have any financial problem, then we have to guide the patient to maybe a social worker who can help with some concessions or something. Okay, so for these things we need to know all the other factors which are affecting our patient. Okay. Now, what does a rehab team consist of? Rehab cancer rehab team will have everyone like physiotherapist, occupational therapist, dietitian, speech and swallowing therapist, counselor. All these people will collectively help a patient get better. Now, today we will see about the role of physiotherapy in cancer management. So basically, physiotherapy principles will remain the same. Okay, it's not that in cancer we are using some different physiotherapy principles or anything. The basic physiotherapy principles which we have been learning from our UG days, that those remain the same. Okay, only thing is in cancer we have to identify the red flags first for each and every patient. The red flags have to be identified, and then accordingly we can go in for whatever is the requirement. So we usually take care of the respiratory system, then we work with the mobility, strength, endurance. We try to make the patients functionally independent in the day-to-day activities. Pain is one of the major factors in cancer patients. So that has to be managed, and ambulation to be taken care of. So now I will just cover in short about what all things we do in different cancers. Okay. So first, let's start with breast cancer. Breast cancer is the most common cancer in females. Okay. So in breast cancer, there are two types of surgeries usually that happen. One is the breast conservation surgery, and the other one is the MRI, that is modified radical mastectomy. So the entire breast is removed. In breast conservation, only the tumor part of it is removed. Okay. Now these two procedures can be accompanied with either axillary sampling or axillary clearance. What is axillary sampling? Axillary sampling is when only few lymph nodes are taken out from the axilla. Okay, and axillary clearance is when the entire group of lymph nodes is taken out from the axilla. Okay, so why do we need to know this? Because the patients who have undergone axillary clearance, they are more prone to develop lymphedema in future. Okay, so that's why knowing what procedure the patient has undergone is important for us. Then many a times there is reconstruction which is done in breast surgery. So now there are various flaps which can be taken. Some are local flaps, some are regional flaps. Now here you can see it's a latissimus dorsi flap where the latissimus dorsi muscle is removed from here and just turned around and fixed in the anterior part of the chest to reconstruct the breast. Okay. Then sometimes there is a distant flap, wherein like here you can see transverse rectus abdominis matrix flap. Now here the rectus abdominis is taken from here and it's transposition going here, reconstruct the breast. So why this is knowing about this is important? Because when this reconstruction surgeries take place, we have to delay our exercise programs, okay, by at least 5 to 7 days, because we need to give time for this microanastomotic microanastomotic surgeries, basically the vessels to to start functioning properly. Okay, so that's why having a proper communication with the surgeon is important. Okay, so if there are no flaps or there is no reconstruction, then usually on postoperative day 1 we start with our exercise sessions. Okay, so usually we if there are a lot of patients, we prefer taking a group session for them. Obviously not in the times of COVID, but otherwise we prefer taking a group session wherein we tell them about the drain and wound care. If you must have seen breast patients, you must have seen there is a drain which is connected to the chest wall. Okay, so how to clean that drain? That has to be explained. Then patients are usually worried that they cannot have bath or they should not wet the sutures, suture line. But that is not the thing. In fact, we insist that they should keep the area clean and they should have bath daily. Okay, so all those things have to be mentioned. Then there is something called as arm and skin care. So as we have seen that there is removal of lymph nodes. Now because the lymph nodes are taken out, there are chances of development lymphedema, right? So for that, there are certain instructions which we need to give them, which we give them in the form of do's and don'ts. So basically, we ask them to avoid any constricting clothes. So very tight sleeves or anything have to be avoided. Any tight threads which are tied usually to the hand, that has to be avoided. Then clasp bangles can be avoided. Instead, they can wear maybe metal or gold or silver bangles. So these type of instructions have to be given. Basic idea is frequent injuries have to be avoided. Now, why is that to be done? Can anyone answer? What happens if there is constant injury or constant constriction on the arm? Why? Why would it predispose lymphedema? So basically, what happens is if there are continuous injuries, as we know, that area will have increased blood supply, right? So then, because of increased blood supply, obviously along with that there will be the fluid also which will be circulated to that area, and then the flow of fluid again to the main circulation might not happen that well, and it might start accumulating in the arm, and as a result, lymphedema will be present. Then we also give option of breast prosthesis for the patients who have undergone MRI. Okay, we have silicone breast prosthesis, or sometimes we even get cotton breast prosthesis, which the patient can use. Now, in this, what happens is, in market there are some prostheses which are available, which are very light in weight, and they have no like they will just give a cosmetic appearance. But what we prefer is something with weight, because the original breast had some weight. So obviously it's better to compensate with something which is equal in size and weight. Okay. Then we teach them exercises. So initially we just keep the exercises standard and same for all the patients. Then later on we can modify the exercises depending upon the patient's individual patient's requirement. Okay. So what exercises we include is mostly shoulder flexion, shoulder abduction, retraction, scapular retraction, ball pumping exercises. Okay. So all those things are included. Now, self-breast examination is a very important topic which we tell the patients as well. And I would like to tell you all also that this is something which has to be done by every female at least once in a month. Okay. So because breast cancer can be easily diagnosed by the self-breast examination itself. You don't need any higher imaging technology for this thing, at least to diagnose it, like to come across it in the first. So there are two parts for the breast examination. First is observation, second is palpation. So as you can see in this three images, first you have to observe. You have to stand in front of a mirror and you have to look for the level of the breast, level of the nipple, and size of the breast. Okay. Then you have to move your arms first to 90 degrees and then overhead, and then check if the breasts are also moving equally, or one is moving, one is not moving. Okay. Then second step is palpation. So you have to palpate it. You can palpate either from in to out in a circular form, or out to in, or in the form of spokes, or in the form of lines up and down. Okay. So that you are covering the entire area of your breast. Okay. This has to be done every month, once in a month. Okay. And you have to, as medical professionals, you also have to pass on this information to your friends, your family, your neighbors, everyone. Okay, because this helps a lot in coming across, like identifying breast lumps. Then, what are the possible complications in the post-operative period? So, post-operatively, there is pain. Sometimes the scar tissue might get adhered to the chest wall. Okay, now because of these two things, there can be reduced shoulder range of motion. Okay, then sometimes there is seroma that gets formed. Now, what is seroma? Now the breast tissue is removed, so there is some space there, some vacuum there. So the fluid starts accumulating in that area, and then that presents as a swelling there locally. So that is something called seroma. So if the fluid which is accumulated is very less, then there's nothing to worry about. It will automatically be taken up by the circulation. But if it is large in quantity, then the surgeons might decide to aspirate it. Okay. So then there is something called as axillary web syndrome. Now, axillary web syndrome looks something like this, wherein the lymphatic fluid basically gets stagnant in the lymphatic vessels. So it appears like a cord. Okay, then this cord causes pain in abduction or flexion or overhead movements basically for the patient. So here also you can see on the elbow there is some cord. Here and the axilla there is one big cord. Okay, so all these things are there. Then, so for this, there are various exercises which we can use in different combinations like range of motion, stretching. If there is pain, we can use TENS. Then we can use moist heat, but then we should avoid excessive heat. It has to be done with extra padding. Okay, because again, extra heat, like it will cause vasodilatation, more circulation, then again, chances of lymphedema might increase. Okay. Then coming to lymphedema. Now, lymphedema is in itself is a very big topic. Okay, so I won't be going into details, and it's more of a practical topic. So it won't be possible to take it right now. Okay, so basically here you can see in the picture this these are the group of lymph nodes in our body. Okay, now during breast surgery, this axillary lymph nodes will be taken out, either few or the entire group of it. Okay, so because of this, the circulation, the lymphatic flow of the arm would be affected. Okay, and because of that, the fluid might just start accumulating in the arm, and which might present as lymphedema. Now, lymphedema has different stages. Okay, now International Society of Lymphology gives 4 stages. Okay, so in stage 1, there is very little swelling, but that swelling reduces with elevation. When you elevate your arm, the swelling will reduce. Okay, then stage 2A, there is swelling, but elevation might not reduce the swelling. So this is 2A. Okay, then in 2B, there are a lot of fibrotic changes. Okay, so pitting may or may not be there, but there are a lot of fibrotic changes which are there. Okay, and in stage 3, it is elephantiasis. So basically, there will be folds in the skin and the shape will be distorted. Okay, so there are different stages of lymphedema. And the treatment, also for treatment, there are various modalities available like compression stocking or multi-layer bandaging or intermittent pneumatic compression or combination of 2 or 3 things. Okay. And then coming to head and neck cancers. In head and neck cancers, like in head and neck region, there can be cancers of tongue, buccal mucosa, maxilla, mandible, larynx, pharynx. Okay, and along with that, as we had seen in the previous picture here, there are a lot of lymph nodes in the cervical region also. So depending upon which region is affected, the group of lymph nodes also will be detected. Okay, so now there is self-examination for mouth also. Okay, so if you like, this is also important, and especially if you know somebody who's used to eating tobacco or pan or hookah. So especially in them, it is very important that they keep a regular check on their oral cavity. Okay, so again in this also you have to first go do an observation. So you stand in front of a mirror, you check for both the sides of your face if there is any swelling or any lump or anything abnormal that you can see. Okay, then you have to pull your lower lip down and check for the insides of the lip. Then you have to check for your tongue. You have to check for your cheeks from inside. You have to put your finger and palpate the insides of the oral cavity, the floor of the mouth, the roof of the mouth. If there are any patches, sometimes there are red patches, sometimes there are white patches. So those things have to be checked, and if there is anything abnormal, you have to at least check and get the investigations done. Okay, so that is important. Now, in head and neck surgeries, most of the times the surgery will be accompanied by some of the other kind of reconstruction. Because what happens in cancer surgeries, it's not that you're just excising the tumor. Okay, even if the tumor is small, some amount of normal tissue surrounding the tumor also has to be excised. Okay, because we don't know what to what extent the tumor has spread. Okay, so some amount of normal tissue is also excised. Now, in head and neck region, the structures are very small. Okay, so if you have to take out the normal tissue also, then obviously it's going to leave some of the other defect in the oral cavity. Okay, so that defect is usually filled with some of the other flap. It can be free or it can be free flap, as in a distant flap or a local flap. Now here in this picture, you can see it's a PMMD, that is pectoralis major myocutaneous flap. So here the pectoralis major muscle is that on the chest. And it is turned and put in the oral cavity wherever the defect is there. Okay, so in this patient, it is very important to work on the shoulder movements. Okay, because pectoralis major is one of the important shoulder muscle, but then it is removed and put in the oral cavity. So then this shoulder might have some dysfunction. So you have to work on that. Okay. Now this is a nasolabial flap. So this is just a local flap again. Okay, it's just a local reconstruction which is done. But at the same time, there are different flaps like FFOCF, which is free fibular osteocutaneous flap. Now, fibula is a non-weight-bearing bone. So when a mandible is part of mandible is taken out, fibula is used to reconstruct that part of the mandible. Then there can be flap, which is a free radial artery flap. So a flap from the forearm is removed and put in the forearm cavity. So, so basically, head and neck surgeries are a lot disfiguring. So again, when there are flaps, when there is reconstruction, you have to delay your exercise sessions. In PMMC, we can start on post-operative day 1 because the blood supply of the muscle is intact because it's regional flap. But when there are free flaps, when there is microvascular anastomosis, then in those cases you have to delay your exercises for at least 5 to 7 days. After a green signal from the plastic surgeon, you can start with exercises. So in head and neck surgeries, what we look after is mainly after the shoulder and neck exercises. Okay, so that is one thing. Then mouth opening exercises because of the sutures, because of the reconstruction, and later on because of radiation. The fibrosis sets in and the opening of the mouth reduces, trismus might develop. So then if the mouth is not opening properly, patient will have different problems in eating, in maintaining oral hygiene. Doctors will face problem in having a checkup of the oral cavity. So because of that, mouth opening is very important. So we use a jaw stretcher key after the sutures are removed, or if the jaw stretcher key is not available, we can use ice cream sticks. We can just stack up the ice cream sticks and increase it one by one. Okay. Then in these patients, sometimes when there is a PMMC and there is a suture on the chest wall, so we have to concentrate on thoracic expansion exercises. Okay. Then ambulation, especially if the flap is from the lower limb. So then in that case, sometimes for the initial few days, we ask the patients to walk non-weight bearing with the help of a walker. Later on, they can gradually increase the weight bearing. Then donor area rehab also has to be done in a lot of cases. Okay, sometimes the quadricep muscle is taken, a part of quadricep muscle is taken. So then in that case, again, working on the donor area becomes important. As I mentioned in PMMC also, shoulder rehabilitation becomes an important topic. And also speech and swallowing therapists play an important role in these patients. Now coming to bone and soft tissue tumors. Again, bone and soft tissue is a very huge topic, okay, and it cannot be completed in a small, like in one session. So now in bone and soft tissue, what happens? First, we'll see the upper limb tumors. Again, most of the commonly the tumors are in scapula, humerus, and radius and nerve. So this is an image of a total scapulectomy, where the entire scapula is replaced by a metal one. Okay, and the humerus, upper end of humerus. Now these implants are very expensive, so not many patients would opt for these. Okay, so these surgeries are rare. But otherwise, in scapulectomy, like if only a part of scapula is removed and the glenohumeral joint is fine, then a good outcome can be achieved in those patients. But if the entire scapula is removed and the glenohumeral joint is also affected, then obviously the outcomes would reduce. Like you have basically, why do we need to know this is so that we can set our goals, like how much can be achieved, how much range can be achieved for that particular patient. So and also we can guide the patients accordingly, that we are not setting unrealistic goals for the patient also. Okay, so that is why the surgeries are important, like knowing what surgical procedure has been done and how much of the muscle is removed. Because in most of the times in bone and soft tissue tumors, along with the bone, a lot of soft tissue, that a lot of muscle mass is also taken out. Okay, so then obviously if there are no muscles, then those movements will be affected. Those movements might not come to a full range. Okay, so that's why knowing how much muscle is lost is also important. Same way in lower limb tumors. Now, lower limb tumors, most of them are found in pelvis or femur and hip. Okay. Now, in pelvis, there are two types of surgeries which happen. One is external hemipelvectomy and one is internal hemipelvectomy. Now, external hemipelvectomy is when the entire pelvis along with that limb is removed. Okay, so there is no limb, no half pelvis, hemipelvis. Okay, so that is external hemipelvectomy. Internal hemipelvectomy is something where only a part of pelvis is removed. And there are various types of it, type 1, type 2, type 3. Sometimes it's combination, type 1 and 3. So now in 1, it is just the iliac portion of that ilium pelvis which is removed. Okay, so in this case, the weight bearing can be full because the acetabulum, the hip joint is normal. So weight bearing can be full and there is no problem with that. Then in type 2, the acetabulum is removed. Okay, and a mesh is used for reconstruction. In this case, obviously, you cannot allow the patient to wait there right from day one. Okay, you have to wait for at least 6 weeks to, that mesh to, like for fibrosis to settle. So likewise, there are different types of surgeries in which different portions are removed. So you need to know what type of surgery has been done. Okay, and accordingly, you plan your program. Okay, so now again in femur, and this is the mega prosthesis. Basically, it's a huge prosthesis. Again, not opted by a lot of patients, but again, here a lot of muscles might be gone, but this can be treated as a hip replacement. Okay, this surgery can be treated as a hip replacement. Same way, there are knee replacements also. Okay, now knee replacements, there are 2 types. Here, if you see, the upper end of tibia is replaced. Okay, there is no tibia, the bone is not there, it has been replaced by an implant. Okay, same way here, the fibula is cut. Okay, and an implant is. So now this is the tibial TKR, this is a femoral TKR. Okay, one major difference in these 2 types of TKR is here there is a tibial tuberosity. Okay, where the quadricep tendon is attached. Now, in this surgery, that has to be removed and it has to be resutured to this implant. Okay, so in this case, in tibial TKR, we don't allow knee bending for at least 6 weeks. Okay, no knee bending, no forceful contraction of quadriceps because that might dislodge the tendon which is resutured to the implant. Okay, so that's why that care is to be taken. Whereas in tibial TKR, there is no problem. You can bend the knee and right from day one, there is no problem. Okay, so these small things are there which have to be taken care of in oncological surgeries. Okay. There are certain surgeries called as rotation-plasty. Amputation is same, like we have studied in our and the rehab also will be same for amputation. In rotation-plasty, what they do is here you can see there is tumor here around the distal part of tumor. So they will take, and if the vessels are free, the nerves and the vessels are free of tumor, then they will just take out the bone and soft tissue part of it. They will rotate the lower part of the leg 180 degrees and they will resuture it. Okay, so now what happens is your ankle is acting as your knee joint. Okay, so ankle dorsiflexion is your knee flexion and ankle plantar flexion is your knee extension. Okay, so you have to work on the ankle and you have to gain some extra range in the ankle. Okay, because knee ranges are higher than the ankle ranges. Later on, when a prosthesis is fit, okay, so the strength also has to be good because it has to bear the weight of the prosthesis. Okay, so this ankle is acting as a knee joint. Okay, that is for this rotation. Then coming to thoracic tumors. Now thoracic tumors have 2 categories. One is lung tumors and one is esophageal tumors. Okay, now in lung also there can be various types. Like only if a small portion of lung is removed, it's a wedge dissection, or sometimes if there is metastasis in the lung and that has to be removed, it's called as metastatic tumor. So in that, only a small portion of the lung is removed, rest of the lung is fine. In lobectomy, the entire lobe of lung is removed. Okay, and in pneumonectomy, entire lung is removed. So in these cases, thoracic cases, chest physiotherapy plays plays a very important role. Okay, and if you started pre-operatively, like pre-operative pulmonary rehabilitation, it's extremely important. Okay, so for lung patients, for thoracic patients, rehabilitation is very important. Okay, so you have to start with pulmonary rehabilitation and post-operatively also you have to work on these patients because post-operatively, especially in pneumonectomy, only one lung has to work and has to compensate for the missing lung. Okay, so there is a lot of stress that is put on this one lung, so it has to work that way. Okay. Then in esophagus, there are 2 types of surgeries again. One is transhiatal esophagectomy and one is transthoracic. So in transhiatal, one incision will be at the nape of the neck and one over here on the abdominal wall. Okay, and usually what they do is they excise the part of esophagus which has tumor. Okay, and they will pull up the stomach. Okay, they will pull the stomach up, so stomach eventually becomes a tubular structure. Okay, in these patients. So again, in these patients in thoracic, there will be one incision at the posterolateral side of the chest wall and one over the abdomen. Okay. So now in this patient, also thoracic expansion exercises, diaphragmatic breathing, and all those things become important because of the sutures, the position of the sutures. Okay. But at the same time, you have to be very careful. No percussion, vigorous percussion has to be avoided. Then head low positions have to be avoided. All those things have to be taken care of. Forceful coughing has to be avoided. Okay, so that's why all these things are important. Like, what surgery the patient has undergone, knowing that is important. Okay. Then gynecological cancers. In gynecological cancers, mainly there are two types of problems that the patient face. One is vaginal stenosis because of radiation, because of surgery. There's the vaginal canal becomes little stenosed. Okay. Then in that case, again, the follow-up checkup becomes difficult. It might be painful for the patient. The patient might have some bleeding. Okay, so those things can happen. So for those patients, we have something called as vaginal dilators. These are cylindrical tubes of silicone which are available, and they are available in various sizes. So depending on, like, we do a PP examination, we check how much stenosis is there, and depending on that, we give them these dilators, and we ask them to use it every day. So then at least the vaginal walls become a little supple, and the stenosis is taken care of. And sometimes because the pelvic floor is handled, the patients might have incontinence. So for that, again, we have to manage that. Then in coming to pulmonary rehab. So pulmonary rehab can be used, as I said earlier, in thoracic tumors or even in gastrointestinal cases or even gynec cases with very long laparotomy scar. So in all those patients, pulmonary rehab would be an important thing. Okay, so usually we prefer having a pre-op session wherein we teach them the use of spirometer, we give them different breathing exercises, we tell them how to cough with splinting. So all those things are taught to them pre-operatively, and then in post-operative period, again we go to them, we make them do the same exercises in bed mobility on post-op day. Then we try to make them walk also, like organ mobilization is important in these cases. And then ICU, if there is any patient who is admitted in ICU in the post-op period, or if a patient comes to an emergency, so the ICU management remains the same as we do it for any other case. Okay. Now coming to chemotherapy, what happens when a patient is undergoing chemotherapy? There are various drugs, and they are used in various combination depending upon what type of cancer the patient is having. And each of the drug will have its own side effects. Okay, so common side effects which the patient undergoing chemotherapy faces is nausea, vomiting, hair loss, edema, all these things. Okay, so now we cannot play a role in everything, but there are certain things where we do have a role to play. For example, if there is a peripheral neuropathy or myopathy, so then in that cases we can teach them certain exercises, some sensory this thing. So those things can be taught to the patient. Then if there is cardiopulmonary toxicity, we can again work on the rehab part of it. If there is pulmonary fibrosis or consolidation, again pulmonary rehabilitation is an important role for those patients. Okay, so that is it. Then radiation, what happens is because of high doses of radiation, there is fibrosis of the skin and the underlying tissue. So depending upon which area the radiation is given, the patients will show symptoms. Like for example, in head and neck cases, this is the region where the radiation is given, so the patient might complain of trismus, mouth opening is reduced, or neck ranges are reduced. Okay, if it is on the chest wall, the patient might have pulmonary fibrosis. Then in that case, we need to tell them breathing exercises, okay, thoracic expansion exercises. Then that's it. So it depends upon which area the radiation is given to. The patient might show some of the other symptoms. That has to be taken care of. Now, xerostomia is dryness of mouth. Now in xerostomia, we cannot do much, okay, because of all the salivary glands and all also lose their function. Because of that, there is dryness of mouth, but that takes some time to recover. Then coming to palliative care. Palliative care is also a specialized medical care, and it is very important aspect of cancer care. Okay. Usually palliative care is associated with end of life care, but that is not the thing. Okay, it can be started in the early stages as well. Okay. Usually palliative care or palliative form of treatment is something wherein you don't have curative solution for the patient's problem because the disease is spread so much in the body. Okay, so you don't have a proper surgery there which can take out all the tumor because it's already spread in the body. So you just for relieving the symptoms of the patient, you can take out whatever part is causing problems to the patient. Same way, there are chemotherapy and radiotherapy doses also available for palliation, which is little different than the curative intent. Okay. So that is there, and yeah. So basically, the goal of palliative care is to improve the quality of life, okay, for the patient also and for the family members also. Because when there is no active treatment available, even the patient is little disturbed, the family members are disturbed, okay, by looking at the suffering of the patient. So we try to reduce the suffering of the patients to the extent possible. So again, palliative care team is a big team consisting of all various professionals like physiotherapist, occupational therapist, then pharmacist, nutrition, psychologist, social worker. Okay, so all these people will work for one patient, and the main goal would be to reduce pain or any physical symptom, to reduce the psychological distress of the patient. If the patient has any social or psychological issues or spiritual issues, to address those. Okay, and to see to it that whatever time the patient has, the patient lives it with minimum symptoms. Okay, so that. Now, just a small information about what all courses are available in Physiotherapy. So, 1 year fellowship program is running in Tata Hospital in Mumbai, okay, and also in Varanasi now. So, if anyone is interested after completion of the PPT or MPT, can enroll for these programs. Okay. Then there are lymphedema workshops which happen every year. Now, since past 2 years because of COVID, it has not been happening because, as I mentioned, it's a practical hands-on workshop, so it cannot be conducted virtually. Okay. Then also in TMH, you can go for observership if you just want to know if you can, because handling cancer patients is not everyone's cup of tea. Okay, because many of us also being into medical field, also we might be affected looking at the patient or the patient's problems or their suffering and all. So if you just want to see if you can, work with cancer patients, or you can go for a short duration of observership in the hospital. Then there are 2 colleges which are offering post-graduation programs. So you can think about doing that as well. Okay. And where can you go after doing all this therapy? So basically there are cancer hospitals, new and new cancer hospitals which are coming up. So definitely in future there will be a lot of scope even in private hospitals. There will also demand for therapists. Then you can start with the specialized cancer rehabilitation center. Or there are various palliative care centers also which require physiotherapists. So these are a few places which can develop. Any questions?
Thank you, Dr. Gayatri ma'am. It was really an informative and wonderful session. Means you have emphasized the importance of physiotherapy in various cancer conditions. The statement which is famous for physiotherapists, that physiotherapist adds life to the ears, that will be justified by role of physiotherapist in variety of cases. So it was really an informative session. Thank you so much. Now I would like to invite questions from participants. There is one question that what is the procedure for 1 year oncology fellowship program in Tata Hospital?
So there are like basically the advertisement goes on the website of Tata Memorial Hospital. So you can check that, and you have to apply. There is an application form which will be there. So you have to apply, and they will go through it. They will call you for interview. You have to appear for the interview, and then based on the marks, you will be selected.
And the fees, duration, everything is there on the website?
Yeah, all the details will be there. Now, I think the next batch would start somewhere around June or July. I think July it will start. So somewhere around May to June, you can keep a check on the website. The advertisement will be out there. And there will be some amount of deposit that you have to pay, which you'll get back at the end of the year, probably. And 6 months of training and 6 months of internship. That is how the program is basically divided into. So all the details will be put up on the website.
Okay, thank you, ma'am. And another question is how manual lymphatic drainage for lymphedema that differs from general massage.
So in massage, usually what we start is from distal to proximal, this part of the limb or the body, that is what we cover. But for lymphedema, first we have to drain the proximal portion. Okay, like for example, if it's upper limb lymphedema, so we have to clear the proximal part first, so that we can make space for the fluid from the distal portion of the arm. So we have to drain that. Then we have to come to the distal, the proximal portion of the forearm. We have to clear that portion. So it's like basically we are breaking it into parts, the arm into various parts, and then we are clearing the proximal surfaces first, and then we are moving to the distal. And that is how we go for manual lymphatic drainage. And the technique is also a little different than the normal techniques that we use in massage.
Thank you, ma'am. Anybody would like to share the feedback about today's session?
Nupur ma'am, I would like to share something. Hi Gayatri. How are you? Yes, nice to see you. Yeah, it was really elaborate session, and I think you have covered all the points from the basic, how to palpate and how to identify the early signs, even the red flags in the cancer, as well as how to do with the treatment part. So it was really wonderful lecture, and I hope all the participants and our students must have learned that there is no limit for physiotherapy. We are in every field and we can conquer all the fields. And student hopefully will get encouraged to do more and more of the onco rehabs and various other specialties as well.
Yes.
So it was great seeing you again.
There is one more question from participant side. Is there any specific treatment for various stages of lymphedema?
Yes, so basically, if, as I said, if it is stage 1, the swelling usually reduces on its own. So you don't have to do anything specifically, just the ball pumping exercises can be done more frequently. Now, if it is early stage 2, usually giving them just a compression garment will suffice. But if it is late stage 2 or stage 3, then comprehensive treatment wherein you put intermittent pneumatic compression, you apply bandages, you apply, then later on you give them the compression garment. So all those things would be there in late stage 2 and stage 3. So it will vary depending upon the stage of lymphedema.
Thank you. And the next question is related to brachial plexopathy. One of the physiotherapists has seen a patient with brachial plexopathy along with lymphedema. So does paradism under pressure advisable for such cases?
We don't usually use paradism under pressure for lymphedema. Okay, we prefer manual lymphatic drainage. So that is something.
Okay. And can you suggest some other modality over paradism under pressure for the management of lymphedema?
Yeah, that's what, like modalities we generally avoid because there is not much research because of ethical this thing. concerns regarding the modalities that are used in cancer management. So safely we can use TENS and electrical stimulation for like wherever required, but otherwise we generally avoid the use of any electrical modalities for our patients.
And ma'am, what is your opinion about intermittent pneumatic compression device in case of
Yeah, so intermittent pneumatic compression, like instead of MLD, because MLD can be a tiring this thing. So if you don't want to use MLD, we can use intermittent pneumatic compression. But again, be it MLD or intermittent pneumatic compression, just giving that is of no use. If you are using that, you have to reinforce it with either bandaging, like some form of compression, either bandaging or a compression garment, depending upon the stage of lymphadenema. Because if you just apply pneumatic compression and you leave it, again, once the arm is in the dependent position, the fluid will start accumulating and you will not see any difference.
Thank you, ma'am. And what is the generalized protocol? In which generalized protocol can be given in hospice care unit?
In generalized protocol for?
In hospital care unit.
But for which particular field? So,
I request Sai to be specific about the question, means which protocol you want to ask, ma'am. Okay, till the time she elaborate her question, we'll take another feedback.
Can I go ahead?
Yes, Dr. Priyanka, please go ahead.
Very good morning, good afternoon, ma'am. Thank you so much for the question. So I have one question which goes this way. So I was seeing a patient post MRM. She underwent MRM 6 years ago. So now she has this complication that she encountered about a year ago. So she had brachial plexopathy. So she lost all her sensations throughout the course of all the 3 major nerves. She had wrist drop also, and her lymphedema is not reducing. So like it can be seen as a permanent neurological damage that has been caused. So ma'am, have you encountered such cases, and how can such cases be dealt with? Because there's some sort of irreversibility that we see, and it's not just physical, it's not just the physical impact that the patient has, it's a lot more psychological, because all her ADLs were affected, and simple things like donning and doffing also are very difficult. So ma'am, what is your take on such things? Because it was a very serious complication.
See, for now, if there is lymphedema and there is a sensory loss, then we usually don't give any form of compression, because the patient might not be able to judge the tightness of the bandaging or the compression garment. It might lead to some blisters or something on the hand. Okay, so that's why we don't generally go for compression. So passively, you can make her do some exercises, and mainly, as you said, she will need a lot of counseling. So maybe sending her to a proper counselor would help, and whatever passive or active assisted movements that can be done for her, or the use of some splints or anything if required. So only those things. Like we cannot do a lot when there is completely neurological loss in her treatment.
We were going ahead with sensory training also, ma'am, but that did not help her 100%. Of course, there was improvement, but then movement was very difficult. When her sensations were coming back, movement was not, even after that. So, ma'am, I just wanted to know what is the maximum that we can do? Even modalities are contraindicated in this case then.
Stimulation can be used. So, if you think that the nerves are like there is scope for thing, you can use stimulation, electrical stimulation.
Thank you so much. Thank you so much for answering my question, ma'am.
Okay, we'll go back to the question again, that what generalized protocol can be given in hospice care unit.
Hospice care or hospital?
Hello.
Yes, I go ahead with your question.
Ma'am, am I audible?
Yes, please go ahead.
Ma'am, I just wanted to know that what is the protocol or generalized protocol which can be given for the hospice patients where the patients are residing with the last stage with a minimal hope, and means there are many patients who are suffering from cancer but with a very minimal hope. So what generalized protocol can be planned for them?
See, for palliative patients or patients towards the end of the life, it will vary depending upon what symptoms. It would mainly be symptomatic management. So depending upon what symptoms the patients are presenting with, we can manage. So most of the patients that are in that stage have some of the other kind of pain, which we can use TENS to help relieve that. And they have dyspnea. So if they have dyspnea, then we can give them dyspnea relieving techniques or some breathing exercises if possible. And because they are spending a lot of time in bed, if possible, then active limb movement so that we can prevent DVT and other complications. Okay, turning in the bed. So all those things we can tell them.
Okay. But ma'am, the strength it is it is very weak. The patients are very weak, and means what goal-directed activities can be something they can that patients can be engaged.
Yeah, so then again, it will depend upon what condition the patient is going through or what stage the patient is in, and how much is the patient able to do. If the patient is able to, say, sit at the edge of the bed, we can make that and make him do light activities. At least, like initially, we begin with just the active movements of the limb if possible. If not, active assisted, like that. But if the patient is having good active control, then we can give him like reaching activities. If the patient is able to stand, we can make him or her stand at the edge of the bed. So it all depends upon what presentation the patient is giving. Okay, so it will depend on that.
Okay,
There
thank you.
A protocol for end of life session.
Okay, thank you, ma'am.
Thank you so much, ma'am, for answering all the questions. It was really an enlightening session for all the participants. And you have also elaborated the various aspects of physiotherapy along with the courses which physiotherapists can do for specialized care in cancers. So thank you so much. Now I would hand over to Dr. Pradnya.
Thank you, ma'am. Now I request Dr. Dipali Hande, ma'am, HOD from Department of Community Physiotherapy, to share some words.
Good afternoon, all of you. I know for any alumni, it's a very precious thing to speak or to deliver any kind of activity for their own college. So I know today Dr. Gayatri must be feeling very proud. And I just want to share a few things about her. She was very enthusiastic when she was in the college. And I still remember that she used to carry big, heavy backpacks when she used to work with the drama backstage. I hope she remember all those things. And I would like to ask Dr. Gayatri, she can share some memories of her during her college life, so that even our students will be motivated, and even they will feel a proud part of the institute.
So, like for the longest of time, like even today, I would say that going to Pravra and spending those 4.5 years there was like the best decision that I have made in my life, because those 4 years were actually very different and very nice. We made a lot of memories. Like it was the first time that we moved out of our comfort of the house, and we spent 4.5 years initially with the strangers who later became like friends, and very good friends. And the good part is we are still in touch with each other. So that's something which is really wonderful. Then I was going through the video that was played in the beginning. It just took me back to all those memories, and it is like very nice to see the campus change so much and the department flourish so much. So I really wish to come there soon and have a look at it personally. So yes, and even the Padmanjali photos, like that reminded me of the Padmanjali week, like how we spent almost a year, a month for preparing for everything. So it was really wonderful experience staying there. And today, actually, as you said, ma'am, it's like it feels great to come back to the college and give a talk here.
We are happy to have you with us actually. We hope that this will continue. I will request our principal, Dr. Rakesh Sinha sir, to tell you about today's program. So can you unmute yourself? Can you share your valuable feedback?
Yeah, Dr. Dipali.
Yes, sir.
Thank you. So it was wonderful to have you, Dr. Gayatri. And I think all the students would have been, all the people, all the delegates and students who ever joined the webinar would have surely learned a few things about working with the cancer patients and how they can further progress in the field of oncology. That's what I told, this being an upcoming branch. That's I told you that Karad, they have started a PG in this branch. So we can also look forward about these things to start something like a post-graduation in like oncology. That also is a thing which is there in my mind. So I think all the students should be and getting a first-hand information from somebody who's working with these cancer patients is always better to encourage the students. I think they'll be directly beneficial. They're the direct beneficial of the knowledge what Dr. Gayatri has gained through her work. So thank you, and we'll have many more associations and other webinars and different type of things with alumni. That is what I have already told Dr. Dipali, but I like to have, and I'd like all the alumni to be a part of this institution because they are the ones who can help us in growth, further growth of the institution. So that is what is always good. And thank you once again, Dr. Gayatri, and wish you all the best in whatever you do. Thank you.
Thank you, sir.
And it's well organized, Dr. the organizing team. Thank you.
Thank you so much.
Rakesh sir, we just request you for wait for 2 minutes. We will take a group picture.
Yeah.
Thank you, sir.
Thank you.
Now we request Dr. Parveen to deliver vote of thanks.
Good afternoon, one and all. Myself, Dr. Pradna Dumore, take the privilege of proposing the vote of thanks. I am extremely humbled and honored to thank the Honorable Chancellor, Dr. Rajendra Vikhe Patil sir, and Honorable Vice Chancellor, Dr. V.N. Magre sir, for guiding and supporting us in this significant affair. I express my sincere gratitude to our principal, Dr. Rakesh Sinha sir, for the unseen support for this event. I would like to extend my gratitude to our guest speaker for enlightening us with her knowledge. My heartfelt thanks to teaching and non-teaching staff for their valuable contribution, guidance, and encouragement in all our efforts. I owe a special gratitude to the IT department for being the constant support during this pandemic, making the online webinar, symposium, and lecture possible without any difficulty is due to the IT department. and also acknowledging them for all timely technical support and arrangements, for they have worked hard to ensure that this occasion becomes a memorable success. Last but not the least, I thank my friends, colleagues, and all the participants for your cooperation in making this function a resounding success. Thank you very much. I request all the participants to kindly fill the feedback form link, which is already posted in the chat box. Thank you very much.
You can leave.